Hello everyone. This presentation is going to focus on the intra-aortic balloon pump. Now, it's not infrequent that we see one of these devices connected to a patient in our cardiothoracic intensive care unit, particularly patients who post coronary artery bypass surgery. And there's a certain amount of trepidation and fear that always creeps into the registrars when they know they have to look after a patient connected to one of these at night. And these modern devices are very reliable. They're actually fairly simple in terms of their operation, and we're going to focus through looking at the information that we get out of the machines, when to use them, when not to use them, and how to set them up optimally. This is the typical screen that a balloon pump has, and just to brush over it, the top trace here is the patient's ECG. In the middle here we have the arterial waveform, so this is the waveform of the patient on the balloon pump. At the bottom here is the actual inflation and deflation cycles of the balloon, and we can see if we look at the balloon pump and the ECG that this patient is being augmented on each and every single beat. As far as balloon placement goes, an important thing to always confirm in the intensive care unit, the devices are put in with a Seldinger insertion technique, usually into the right femoral artery, and the position of the balloon is to have the tip just distal to the left subclavian vein. So you want it high up in the descending aorta, but not in the aortic arch. And if we look at a plain chest x-ray, then we can see there is the radio-opaque marker in the tip of the balloon, and we essentially want to see that tip just below the aortic knuckle. Now, these balloons inflate and deflate in an automated fashion controlled by the pump, and we're just going to look at when the balloon inflates and when the balloon deflates. So this slide focuses on systole, and it's important to remember that during systole, when the left ventricle is ejecting, the balloon is deflated in order to allow free flow of blood into the aorta and good runoff. So in systole, the balloon deflates, and this reduces afterload and it reduces stroke work. And perhaps to understand why it reduces afterload and stroke work is, if this balloon deflates just before the ventricle is about to eject, then there's a space left here in the aorta from the deflation of the balloon, and it's very, very easy for the left ventricle to eject into that potential space left by the deflated balloon. During diastole, the balloon inflates and expands, and this increases coronary perfusion. And if we think of this balloon expanding rapidly, it pushes blood backwards here in the aortic arch, and that improves coronary perfusion. And to a small extent, it also encourages distal blood flow in the descending aorta. And so we get an improvement in coronary perfusion and also some virtual improvement in the stroke volume ejected distally. Now, understanding where the balloon is placed, we can think about what its indications for use are, and really the first indication there, the patient with unstable angina, is probably the most common indication. And when I said at the beginning of the talk, we often have patients in our ICU post coronary artery bypass surgery, they've had their balloons inserted by the cardiologist prior to surgery. Also, acute left ventricular failure is an indication, and acute mitral regurgitation is generally accepted as an indication for its use. Also, high-risk percutaneous coronary intervention, high-risk non-cardiac surgery, although this is more contentious, and in refractory ventricular arrhythmias it may also be considered, but probably even more contentious. Contraindications are relatively straightforward. So if patients have aortic regurgitation, the inflation of the balloon would just encourage more regurgitation into the left ventricle and increase the left ventricular end diastolic pressure, so no good there. I think it goes without saying, if you've got an aortic dissection in progress, the last thing you want to do is put a balloon up into that injured aorta. And then also if patients have had prosthetic aortic grafts, so repairs of previous thoracic aortic aneurysms with synthetic grafts, we wouldn't consider a balloon pump for insertion. And this last contraindication is perhaps a little bit more relative, but for patients with severe aortoiliac disease, we try not to put the pumps in. And it's not, or unfortunately not that infrequent, that we have a patient in the unit who has a cold leg post-insertion of a balloon pump. So why put them in? Well, it's all about myocardial oxygen balance. So it's a supply-demand issue. And if we have a look at a cartoon that I've drawn there, that's of a normal arterial line tracing. And then that's followed with a beat that is augmented by the balloon pump. And if we look at what we know from physiology, is we can look at the area under this arterial line trace, and we know that part of this area is related to ventricular contraction. And in fact, we can describe this area here in the orange as the systolic tension time index, and that's a period of time during which the ventricle demands oxygen and consumes it. And the next area that we have over here is the diastolic pressure time index, and that then describes the amount of time and pressure, as it were, available for coronary perfusion and represents supply. And so we have demand and supply available to us as in indexed form from this trace. If we look then at the following beat, so this is the beat that's going to have the balloon augmentation follow it, then the systolic tension time index here is the same as that. But we can see now that following the inflation and deflation of the balloon, we have a much bigger diastolic pressure time index, indicating that there's a much greater potential for supply of oxygen to the myocardium. And then my graphic is not drawn so well, but this beat following the activation of the balloon would in fact be slightly smaller, achieve a slightly lower systolic pressure, and there would be less consumption of oxygen during that period of time. And so the big issue with the use of an intra-aortic balloon pump is that it's an implement to improve the supply-demand ratio of oxygen in the myocardium. We're now going to go through a series of slides that deal with the timing of the balloon pump and getting to understand timing. And clearly, as with many things in life, timing is everything. So to get to work, the first thing we have to understand is what's called the electromechanical coupling interval. And the electromechanical coupling interval is the amount of time it takes from when the ECG, or the electrical part of the heart, first shows depolarization to when you actually get effective ventricular contraction. And that amount of time that lapses between electrical activation and then muscle contraction varies with heart rate. And it varies with heart rate between patients, and it varies with heart rate in any individual patient. But what's important is to know that the systolic time interval is predictable. So if we can measure for any patient at a fixed heart rate what the electromechanical coupling interval is, then we know what the systolic time is, and that interval is predictable at different rates in the same patient. And so we can get our balloon pump to analyze this data for any particular patient, and it then allows the balloon pump to look up in a program how it needs to adjust this interval for any change in heart rate in the patient. And plotted here is the systolic time interval in milliseconds against heart rate, and this is for a group of different study subjects, and what we can see is that in general there's a fairly linear relationship between the systolic time interval and the heart rate. So how is this useful for the balloon pump? Well, if the balloon pump gets triggered by the ECG and the machine knows the electromechanical coupling interval and it knows what the systolic time interval is for the patient, then it can adjust its deflation time reliably across a range of heart rates. So modern pumps are pre-programmed with systolic time interval heart rate curves, and so once they've got the information for any particular patient, then they can predict very reliably how to adjust the timing of the pump with an alteration in heart rate. And it's why most of our modern machines then we just use running in an auto mode, and we don't go and adjust the inflation and deflation of the balloon manually. So now you'd perhaps realize why ECG-based triggering is the most common way of triggering. We can also use pressure waveforms, and we can use a pressure waveform that's transduced from the very tip of the balloon or from any other arterial line that's been inserted into the patient. If we look at the ideal waveform, and we're going to go through this slowly, then there I've put a normal arterial line trace, and I think it's important just to appreciate that we can see there the peak systolic pressure for each of those 3 beats, and we can see the end diastolic pressure for those 3 beats on the bottom line. And important in terms of timing of the balloon pump is we can clearly see where the dicrotic notch is on each one of those beats. So now if we look at what happens when we activate a balloon pump, and we're going to do it here on this beat. So here we can see the balloon pump gets inflated and deflated, and if we look at what the impact of that is on the arterial line waveform, then we can see that the balloon inflates right at the dicrotic notch, so we don't get the normal diastolic runoff of the arterial pressure. We can see that there's an increase in pressure here created by the balloon pump. So this is actually happening in diastole, and we see that this pressure here is in fact higher than the pressure of the preceding beats. And if we look at the end of diastole when the balloon is long deflated, then we can see that we get an end diastolic pressure here that's lower than it would ordinarily be. In the first part of the balloon's activation here, so this is just after the aortic valve closes, we can see we get a rapid rise in aortic pressure, and this is what enhances that coronary flow by creating backflow into the aortic arch, and it distends the wall of the aorta. And that distended wall of the aorta then recoils, and because of the elastic recoil of the drop, the elastic recoil of the aorta, we get this drop in pressure, and we eventually reach a point where we get what's called an aortic plateau. So you can see the pressure trace flattens out a little bit there, and at that point the balloon then deflates, which takes us all the way down to the reduced end diastolic pressure. And we see now in the beat following the deployment of the balloon pump that we have a reduction in peak systolic pressure. And as I showed on my slide earlier, that would reduce that systolic tension time index for that following beat. So in terms of timing of the balloon, I said to you ECG timing has now become the most common and reliable way of deploying a balloon. And that's because sometimes it's very difficult to identify some of the features we want to on an arterial line trace. So patients who peripherally vasodilated, etc., may be difficult to identify the dicrotic notch. And clearly, if we have a transducer which is subject to either over or under damping, we may have difficulties. And for those reasons, ECG timing has really become the norm. And as you can see from this graphic here, the time that the balloon inflates coincides with the exact midpoint of the T wave, and the deflation of the balloon is on the peak of the R wave. So balloon inflation, midpoint of T, deflation at the peak of the R wave. And remember that this balloon is actually deployed, or the machine is active in diastole. The period of time following the peak of the R wave, this would be where ventricular systole is occurring. And so we then get the balloon pump inflating, and the aortic in the dicrotic notch, which coincides with the midpoint of the T wave. We get that increase in pressure, and we get the aortic recoil taking us to the aortic plateau, and then we get the pressure dropping down. So if we know what a normal waveform looks like, and we know how the balloon pump is timed, then we can have a look at some abnormal waveforms. And we're really going to look at the 4 cardinal errors of balloon timing. And the first one we're going to consider is early balloon inflation. Now, if you remember, I said that the balloon would normally inflate at the point in time where the aortic valve closes. That's the dicrotic notch, and that means the balloon then inflates in the aorta while the ventricle's going through isovolemic relaxation. But if the balloon inflates early, then we end up with a problem. And we can see here that the point at which this balloon is inflating is way too soon in terms of this preceding trace here where we can see the dicrotic notch. So this balloon is inflating now while the ventricle is still ejecting. And we actually see an increase in the augmented pressure compared to what it would be if the balloon had inflated at the right time or at the dicrotic notch. But this is a problem. This doesn't make the ventricle's life easy. This makes the ventricle try and eject into an occluded aorta, and obviously the thing that's occluding the aorta is that inflated balloon pump. So when we have early balloon inflation, there are 3 major problems that occur. The first one is the afterload increases, and if the afterload increases, that's the ventricle straining against the balloon, then the oxygen consumption of the myocardium is increased, and also the diastolic perfusion is reduced. We want that balloon to inflate as diastole commences so that we get back perfusion into the coronary arteries, and if the balloon inflates too early, then that becomes a problem. And then last of all, the stroke volume and the cardiac output are lower. And in fact, once we've been through all of the 4 errors of timing, you'll come to realize that early balloon inflation is the most problematic and or dangerous of all the mistimings of a balloon pump, and it's something that you want to watch out is not happening. So if that's early balloon inflation, then we're going to look at late balloon inflation. And perhaps just before I go through this graphic, because I haven't said it yet, but if you want to inspect the timing of the balloon, then you need to switch the balloon pump from augmenting every beat to augmenting every second or third beat, so that you can see what a normal arterial line trace for a ventricular ejection looks like, and then you can see what the impact of the balloon is compared to the normal. All right, so here we have late balloon inflation, and I think you can see that the problem here is that dicrotic notch is visible, and the balloon is only inflating after that point in time, so it's late. And what that does is it gives us a much reduced augmentation. And if you think of that original concept of the diastolic pressure time index, then there's a much reduced diastolic coronary perfusion. And so the hallmark of this one is the balloon inflates after the dicrotic notch. It gives us very poor coronary flow augmentation, and it gives us a reduction in coronary perfusion, and in essence just means the balloon is not providing the support it could or the support it should. Doesn't add load to the ventricle like the early inflation did, but it just doesn't do everything that it should be doing. We're now going to move to the errors in the timing of deflation. And first one we're going to look at is early balloon deflation. And again, if we look at what's happening now, we can see the period of time that the balloon is inflated is very, very short because it deflates too quickly. We can see that aortic plateau that I showed you earlier is no longer there. So we just see the pressure dropping straight down. And if we look here, although we get a lowering in end diastolic pressure, by the time the ventricle has to beat, in fact, the aortic end diastolic pressure has returned to normal. And that means when this next beat beats, we are not going to get the amount of reduction in afterload that we would like to from a ventricular perspective. And there's then no assistance to this assisted beat. So you can see the following beat now, because the aortic end diastolic pressure returned to normal before ventricular ejection, this systolic pressure is exactly the same as the other beats, where when we had good timing, we saw that the systolic pressure of the assisted beat was in fact lower than the non-assisted beats. And then I think just to appreciate the fact that the beat that benefits from the reduction in afterload, etc., is this beat here. So it's the beat following the deployment of the balloon that the ventricle gets the biggest benefit out of. It's had the best coronary perfusion before it needs to contract, and it should have a reduction in its afterload. So early balloon deflation, just to reiterate, the aortic pressure returns to baseline, and that's the thing you want to look at. And as a consequence, there's no reduction in afterload. And there's no reduction in myocardial oxygen usage, and that's because isovolemic contraction is not reduced. So early balloon deflation is a little bit like late balloon inflation. It's not inherently dangerous or problematic, but it means we're not getting the best out of the balloon pump. That brings us then to the last abnormality of timing, which is late balloon deflation. And if we consider the impact of late balloon deflation on our graphic, we can see here we have this prolonged aortic plateau because the balloon stays up for an extended period of time. And we can see now that the end diastolic pressure is raised prior to the next beat. And that increase in the aortic end diastolic pressure leads to a direct increase in afterload and an increase in oxygen consumption. And that's a problem. So the fact that the aortic end diastolic pressure is raised means that the balloon now adds workload to the heart. So if we consider then the four abnormalities of timing of balloons, the worst two are early inflation and late deflation. And late inflation and early deflation just take away the power of the pump to provide the support that it could be giving. And then just to say that with late balloon deflation, one of the commonest reasons that we see that is there's an obstruction of gas flow in the tubing connecting the balloon to the actual balloon pump machine. And then the last graphic I want to go through with you is just that of poor diastolic augmentation. And we sometimes get traces that look like this in our patients. So if we look at this trace, we can see the balloon inflation is at an appropriate time. It's coinciding with the dicrotic notch. So this would not be increasing the afterload of the ventricle. The timing is good. It should give us optimal coronary perfusion. We've got a nice aortic plateau there, and in fact we see that the diastolic pressure drops down, so the end diastolic pressure is lower, and we see that our following beat has a lower peak pressure. So everything looks great, but we're not getting this augmentation in pressure that we usually expect. And this reduced diastolic augmentation is a problem. And it means it looks as though we've got our timing sorted out perfectly, but we're just not getting the benefit that we would like to for the patient. And the reality is, with balloon pumps, sometimes it just doesn't work. And that means we can just look through why it doesn't work. So sometimes if we have a ventricle that ejects a very low stroke volume, then the balloon just inherently has nothing to work with. Patients who have a very low systemic vascular resistance and very vasodilated, there's just too rapid a runoff from the aorta for the balloon inflation to create the increase in the pressure in the aortic root that we're looking for. If we put too small a balloon into a big patient, then even though the balloon is inflating and its timing is perfect, the volume of blood that it displaces is just too small. Or if we got the balloon in the wrong position, so it's too far distal in the aorta, then we can also end up with poor augmentation. And the last two factors there would be that the balloon's not fully deployed, so it hasn't been filled completely with helium, or that the helium pressure is low. So that brings me to the end of the talk, and it's just to say that we do expect you to know something about balloon pumps. They're not that uncommon in our clinical environments, in ICU and in theatre, particularly in the scenario of acute coronary syndromes and coronary artery bypass grafting. And then from an exam perspective, I think the important things are just to know when the balloon inflates and when the balloon deflates, where it's positioned, how the balloon should be timed appropriately, and to be able to recognize abnormalities of timing from graphics or diagrams or traces that are given to you, and then to know what the indications and the coronary and contraindications are. So just in summary then, the enemies in timing, as it were, the two baddies to look out for, and again from an exam perspective, probably the ones we're most likely to show you: early inflation and late deflation, which actually hamper ventricular performance and hamper the augmentation of coronary perfusion. As I said to you, most often now we run the balloon pumps on autopilot, which is based on a pattern triggering from the ECG, because of the advanced programmability of the balloon pumps. And then just to say again, to emphasize, you must be able to identify a normal trace and what its components are, and you must be able to identify abnormalities of timing. And if you can identify the abnormalities of timing, either adjust or comment on, or be able to optimize pump settings. Thank you very much for your attention.